Okay, it's recording.
Okay, so thanks for coming, you guys, and there's a bunch of people on Zoom as well. Laura Powers, who we started our journey together many years ago. Like, how many? 15 years ago, or
Well, your old active life.
in 2010.
Yeah, 2010. Yeah.
We worked together for like 7 or 8 years, right?
Mm-hmm.
And then Laura branched out to doing this expertise, which is very helpful for all of us. And I know for us, so thank you so much for coming.
Thank you.
Yeah.
Thank you. So hi, I feel like I know a lot of faces in here, and some of this might be redundant for a few of you. You've probably heard some of my conversations. So I am Laura Powers. I'm a registered physiotherapist. I have a practice here in Collingwood called Higher Function Women's Health. As Sarah mentioned, I did start in kind of way back when at Active Life, doing some personal training. Sorry for 1 sec. Is there any need to not have feedback in this? Do you know? Sorry, guys. I can hear myself talking. Should be okay. That's better. Perfect. Sorry. You know, when you're talking on the phone, you can hear yourself, and I'm hearing myself speak. Okay. So sorry, guys. So I did start here at Active Life many moons ago. I started with some personal training and have that background, but I had my physiotherapy degree at that point and was also treating patients mostly orthopedically. But I knew very early on that pelvic health was an area that I wanted to focus in. I did my education in Perth, Australia, and their healthcare system and physiotherapy is quite good. I think personally, I had the opportunity of doing a clinical placement at a women's hospital there. And it was quite amazing. We got to go on the ward treating women postpartum, like 2 days postpartum. I don't know how much they actually retained what I told them, but we were educating about pelvic floor, diastasis, you know, just returning to general mobility. And so it really piqued my interest that there was something other than just sport physio, which I kind of always thought that's what I was going to go into. And I still love, I do treat orthopedics as well. So it is something that I love balancing in my practice. But I thought, you know, this is something that was really underserviced when I came back to Collingwood in 2010 and realized that there wasn't a lot of other pelvic floor physios. And we have lots of other physios and chiros in town and lots of great ones. So I wanted another kind of niche to focus on. And that's when I started building my pelvic health practice. And when I started back then, there were very few pelvic floor physios in Ontario in general. So it was really about spreading the good word of pelvic floor physio at that time, and lots of legwork to doctors and nurse practitioners and naturopath doctors, and doing lots of these talks to educate women on how we could help you with some of these conditions and issues. So I grew my practice, and now I predominantly treat just women for pelvic health issues. There is men's pelvic health, which I don't treat, but there are other pelvic floor physios in town that do treat men. I just think the amount of effort that I kind of put into my knowledge and education for women's pelvic health, I just found it hard to try and be as good for the male pelvic health. So just, you know, for our male counterparts, there is that option too, because they also have some different needs. So our talk today is about pelvic health through perimenopause, menopause, okay? And I love that Sarah started this series. I think I had to say for you too, Sarah, that I was really inspired by your like boldness and vulnerability to put that post out on Facebook talking about sort of her journey and acknowledging sort of these changes that are happening to our body as we age and starting this program. So thank you for putting this out here, because it's really important as we age that we know what changes are coming for our body and how we can help support that, okay? And from the talks from Aranka, she kind of set that stage from that naturopathic part, and then Jess with the encouraging and supporting the base of fitness and nutrition that really helps support this. So we're gonna focus a little bit more down into the pelvis, okay? I highly encourage you to ask any questions. I know some of these topics can be quite embarrassing for some people and make us feel a little bit vulnerable. But I think that is the key to making this more common knowledge and acceptance of what happens to our bodies as we age. We need to talk openly and freely about it. And something I try to kind of encourage in my practice is making you feel comfortable to have these conversations. I always love when women come in and we start talking, kind of tiptoe around, you know, what's your bladder health and how do you poo and what are your poos like, and tell me about intercourse. And like, these are very common conversations in my day-to-day, and hopefully by the end we feel really comfortable to kind of talk openly and freely about this. So please ask questions. I'll try and leave some time. I always say as well, I could talk for 2 hours about any one of these topics. So I'm going to try and give you snippets and the most important information that I think you need for this to get a good understanding of how our bodies will change, and try and give you some practical education as well. So does anybody, who knows about pelvic health physiotherapy? Kind of, a little bit. Yeah, we know it's out there. Don't know exactly what we do. Okay. A lot of women come in and have no idea what they're getting into. So again, I am a registered physiotherapist. We focus specifically on issues related to the pelvis, but also sort of abdomen. I see women through the ages, so early in the teens late teens, probably more so, up into 80, 85. So I have a quite varied practice. We deal with issues relating to bladder, bowel, pain issues, pre and postnatal rehab, bowel issues. So there's a huge spectrum of what we deal with. I always say that I do work within my scope of physiotherapy. So anything that sounds a bit out of my realm to help treat, I do refer back to your family doctor, nurse practitioner, naturopathic doctor, if we need some further investigation. So I can't obviously see what your bladder is doing. I can't see your bowels, but I look from that muscular standpoint. So we go through a very thorough history taking. If anybody has seen my intake form, it takes at least 20 to 30 minutes to fill out. It's very detailed because I'm trying to get a good grasp of you as the individual. The approach that I take is called the biopsychosocial model, where we get a good understanding of all those different pieces of the individual. The bio, so your muscles, your tissues, genetics, age, etc. The social aspects, so are you a mother of 5? Do you work full time? Has someone just passed away in your life? All those other elements that might influence our whole nervous system, our diet, nutrition, we have to consider all those pieces. And then the psychological aspects. So I always say I don't diagnose anything. I do not diagnose you with anxiety or depression, but we have to have a conversation around those aspects, because if someone is struggling with depression and I said, okay, great, we're going to start this exercise routine, they're like, I don't have the motivation for that. We have to meet the individual where they're at. If someone is dealing with a lot of stress and anxiety in their life, then again, I'm not going to treat that, but I might be able to give you some sources for exercise or meditation, mindfulness, because we have to acknowledge that stress anxiety is going to influence your nervous system. And then that might be reflecting into some of your tissue issues, whether you're holding tension, or again, maybe while you're eating certain things that are affecting your gut health and your bowels. So again, we try and put this picture together of the individual so that we can create a really good treatment plan. It's not a one size fits all. Yes, I probably teach some consistent exercises to a lot of my patients, but I still have to meet where you're at. So that is an approach that I'm quite passionate about. And we take a lot of time talking and getting to know each other and getting a lot of the details about what your bladder, bowel, sexual intercourse issues are, so that again, we can help create a tailored treatment plan. And most women are really happy because they've never been able to talk so freely and openly about what their issues are. They may have brought up some of their concerns to their family doctor, but I'm surprised by how many people have told me that they haven't spoken to their doctor about leaking issues or pain issues. So it's often the first time they may have actually spoken about it. So I should also say the handout that I've given is trying to follow a bit of the flow of what I'm going to talk about, so you can kind of reference a little bit there. So we've talked about what pelvic floor physiotherapy is. The big piece that I should talk about is the assessment, the physical assessment part. So no shock value when people come to see me. I try and give everybody a lot of notice of what they can expect from our session. So we do a thorough history taking. I do an external assessment, but the big piece that's different is that I do an internal assessment of the pelvic floor. So it is a vaginal exam, digital exam, just using a finger. where I palpate the pelvic floor, assessing what your muscles, tension, tone is like, your strength, how you're doing Kegels, where your organs are sitting internally. And so again, I can help create a better treatment plan and then ultimately give you better feedback on how to be doing certain exercises, okay? So no surprises with that. That's only happened once in my career, and I made sure that that would never happen again, that someone was surprised by what they were coming into, okay? So if we're talking about pelvic health, we need to have a really good understanding about what our pelvic floor muscles are and some of the anatomy. I highly encourage you not to Google some of these issues, okay? Because you will get the worst of the worst and the very scary of some of the anatomy changes, okay? It's not all severe, but it can get to some of those stages. I don't think I've ever not done a talk with my pelvic floor model. And usually when it's in my office, it's chucked in the corner, so it's not fully exposed to everybody. It's a bit intimidating. So we have our pelvis, okay? Everybody can kind of see okay? So we have our pelvis. It's a little bit smaller than actual size, okay? So it'd probably be a small female size, okay? We have our pubic bone in the front, spine, sacrum to tailbone, the two sides of our pelvis, and then the sit bones on the very bottom. I'll try and show this as best I can without the organs falling out, but internally, okay? And I'll bring this back out for later conversation. You have your bladder that sits on top of the vagina, the uterus at the top of the vagina, and then the rectum on the back side of the vagina, okay? So those organs are sitting right on the very bottom of your pelvic floor. And so this is a big piece that everybody thinks that pelvic health is about, is just our pelvic floor and doing Kegels, but there's a lot more to it. So if we take these out, and those will have to go back in, then we're looking down at our pelvic floor muscles, okay? So that very bottom, okay, attaches to the inside of the pubic bone, slings back towards the tailbone, and out towards the sit bones. Okay, that's the deep layer of your pelvic floor. Those are the muscles that create the most bulk of the pelvic floor, that provide a lot of that support and lift and closure that we're looking for helping with continence, okay? But we do have 3 layers, and the first layer that we palpate, sorry, I'm going through my assessment. We can see externally or palpate externally, and it's this little triangle of muscle that supports around the vagina and the urethra, okay? And then you have your clitoris at the top, the clitoris, tomato, tomato. The very bottom, you have the perineum, so the space between vagina and anus, and if anybody's had babies, a vaginal birth, and that has had any tearing or an episiotomy, that is where they're cutting through or may have torn, okay? Also say that that's sort of the main fascial anchor point of the pelvic floor. So it's a good indication of sort of support and tension when we palpate that to see sort of what the state might be like deeper inside, okay? And then we have the anus at the bottom. So again, with the pelvic exam, we are assessing all of that tissue quality. We're looking for color, fullness of tissue, dryness of tissue. We're feeling into the perineum, assessing sort of the general sensitivity and tone of this first layer of your pelvic floor. The second layer is more fascia and sphincters, so we don't actually do a whole lot with that. And deeper inside is, again, that third layer that we really work on when we're looking to do those pelvic floor contractions, also known as Kegels, okay? Yeah, I'll bring this back out as we talk about some of the other issues. But that's a good sort of starting point of like, what are we talking about when we say our pelvic floor? So I always said I was going to try and make this a little bit interactive so that we can gain a little bit of awareness from this assessment. And if you're listening at home, you can join in as well. So if you want to be cross-legged or just sitting tall in your seat, okay, a little exercise to help us connect to our pelvic floor. And I always say, if you find this challenging, especially because we're up and sitting and we're working against gravity, you can always lay down. It might make it easier. And if you find this really challenging, then maybe you need some pelvic health physiotherapy to help you find these muscles, okay? So if you want to close your eyes, if that's easier, it's totally up to you. But I want you to either touch or just visualize where your pubic bone is, where your sit bones are and how they feel on your seat, and your tailbone towards the back. Ideally, we should feel fairly centered for now to start off with. So we should feel equal pressure through your sit bones. If you can, in your mind's eye, visualize where your urethra, where the urine comes out, vagina and anus is. Find those kind of 3 openings, okay? And let's start at the back end around the anus. I want you to visualize that there's a little marble sitting outside, just using the anus. So just in your pelvic floor, I want you to grab that, tightening around it, and then lift it up inside. And I always say that nobody should know that you're doing these. So I shouldn't see people going up and down or shoulders lifting and sucking in their belly, okay? If you're still holding that little marble, relax that marble, okay? Let it go. Yeah, faces, I see people look up to the left, the eyebrows raised, like all of that happens for sure, okay? Great. Okay, so that should have, like, usually that's a little bit easier for most people because that's where the bulk of the pelvic floor muscles are, okay? Next, move vaginally, so it's a little larger opening. We're going to visualize like a little ping pong ball sitting outside the vagina that you're going to grab and pull it up inside. Should feel subtly different, okay? Relax, let that go. Good. And then last one around the urethra. So this is often a sensation like you're going to stop midstream pee, okay? Again, a little raisin sitting outside, using just that urethra, mostly that urethra. You're going to grab that little raisin and pull it up inside. And then release and let it go. Kind of feel those 3 different areas. So often we use that as just a starting point. You know, have you ever done Kegels before? Pelvic floor contractions? No. Okay, well, let's get familiar with our pelvic floor. What does that feel like? Okay. So if you were seated and you were quite bum tucked under, because I saw a few of you sitting like that, I want you to sit tall. And if you were sitting tall, I want you to bum tuck under and change your posture a little bit. Okay. Focus on one of those areas and then do that again and see if that feels different to you. So again, either slouch more and then pick an area and contract, or sit tall if you were slouching and see if that changes anything. It should make it feel a little different, either harder or easier, depending on where you started. But again, our posture will also influence that tension that we can generate in our pelvic floor. So again, with assessment, you know, if people are walking around like this, which I see a lot, okay, and their bum is tucked under, well, that might make them more focused around that sort of posterior aspect, or make them hold a lot of tension in their pelvic floor. Likewise, if people are kind of more lordotic, more sway into the low back, they might be a little bit more focused around the front. Posture will influence that ability to generate tension in pelvic floor. So that's, everybody's a little bit different what they feel with that. But just being aware of how we hold and carry ourselves can sometimes influence how we can generate that tension in our pelvic floor. Okay. All right. So some boring statistics. So 50% of women over the age of 50 will have some degree of pelvic organ prolapse. We'll talk more about what that actually is. But only 3 to 6% of those women will have symptoms associated with their prolapse. So we're going to talk about how we can have prolapse. You may or may not even know that you have one and may not have symptoms associated with it, okay? 50% of postmenopausal women at some point in their life experience urinary incontinence. So it's or urinary symptoms, excuse me. So it is quite common, okay? Between the ages of 40 to 80, there's potentially a 30 to 50% loss of muscle mass, and that also includes the pelvic floor. So that's really fitting in with the information that Jess gave us a couple of weeks ago about the importance of heavy lifting and lifting in general. We need to keep that muscle mass. And that's also one of the training goals of doing Kegels, is like their pelvic floor contractions, is that we're building that muscle bulk of the pelvic floor as well. It's strength training for your pelvic floor, okay? 1 in 5 women over the age of 40 will have anal incontinence, so actually leak poo, okay? So it is a thing, and it's amazing the extra embarrassment that comes with that conversation. I think as a society, we've kind of normalized, we're women of a certain age, may or may not have children, we leak. Oh, let's, whatever, I leak while I run, or, you know, I leak while I laugh, and it's okay. But when we talk about anal incontinence, it's kind of a next level of embarrassment, I find, and it is still fairly common. So we can't ignore that that can happen as well. I don't go into a great deal of that. So if there are any extra conversations that want to be had around it, I'm happy to discuss afterwards. And Sarah and I talked about maybe doing where you're welcome to email me some questions, and then I can put that out to the group afterwards. Again, just knowing that some of this is sensitive for some people, okay? And then also interesting, there was a study where 1 in 2 women cited that leaking was a barrier for returning to exercise. So we have to acknowledge that leaking, although it's kind of been normalized, it can really affect people's motivation, encouragement to get back to doing fitness, which we know can really help improve some of these symptoms as well, okay? So again, we're talking about perimenopause, menopause, and that's a big spectrum as we talk about perimenopause, which can last for about 10 to 15 years prior to that final menstrual period. And during perimenopause, there is this state of actually high estrogen and low progesterone. Because we're having these non-ovulatory cycles where we're not producing an egg, we actually have quite low progesterone. And that's why we see some of these real swings in mood and acne and back issues and fluctuating periods. It's all because of these changing of hormones. But eventually you get to a point where there is this decreasing in estrogen and we stop producing eggs and we have our birthday of menopause. So it's actually one day. You are menopausal for one day and then the next day you're postmenopausal and that's it. And then you're postmenopause for the rest of your life, okay? So you have one big celebration of menopause and then you're postmenopausal. So it's mostly just around the dialogue of wording that we use with that. So you're postmenopausal after you haven't had a period for 12 months. And I think most of the conversations we've had here have expressed that. So it's no period for 12 months. If you do get bleeding outside of that, you need to speak to a family doctor or gynecologist. That is of some concern, okay? And the average age for menopause is 51. So I've recently had a woman who was mid-60s that was still having her period. Sorry for her, yeah. And then obviously there can be women in their 40s that go into menopause as well. So it's just, there's a huge sliding scale. And again, so we're going to talk about sort of varying degrees of issues that can present through that, because perimenopause, you might not have as severe symptoms as those that are, 10, 15 years post menopause, okay? So again, we talked about this decreasing of estrogen that happens, and I know Aranka did speak a lot about sort of more the systemic effects of the hormones in our body. We're going to focus a little bit more specifically to the pelvic floor and some of the muscle or the tissue quality that changes to the vulva-vaginal area, so the vulva and the vagina. Vulva, so we're all clear, is more the external part. So looking at the labia majora, labia minora, coming into where the introitus or the opening, to the vagina, that's the canal that comes in. So a lot of times we talk about vaginal issues when really we're talking about more of the vulva, okay? So there are these vulvovaginal changes, as well as changes to the lower urinary tract that get affected by our decreasing estrogen. So some of those changes that happen, which sounds quite scary. So every year after 35, there's a 2% loss of striated muscle of the urethral sphincter. So there is a muscular component to the urethra, and we actually lose some of that muscle mass. So it makes it harder to create a strong closure around the urethra. So it always kind of sounds like we're being a bit challenged from the age of 35, okay? The bladder itself changes, the elasticity of the bladder changes, so we call it less compliant. And the mucosal lining of the bladder becomes a little bit thinner, and then also a bit, because of that, more sensitive. So in the past, I could drink 3 cups, 4 cups of coffee and not have any issues. Now, if I have that, I'm having to go to the bathroom like every hour, or I find my leaking is worse. That can be because of some of that changes to the actual bladder, okay? Women really hate when I talk about their coffee intake. I had one lady in the intake form, like, do not take this away from me. Like, it's a non-negotiable. So we work, we meet where you're at, okay? Or my glass of wine at night, whatever it is, we meet where you're at. I always say with this stuff too, it's a choice. I'm here to educate you on what your options and what we know from the research. But if you're like, I'm not stopping that, and you're like, it's okay, I'm just know that I'm gonna have to go to the bathroom multiple times, then that's your choice. And at least you have a better sense of control of what's happening to your body versus like, it's just falling away from me, okay? So the bladder changes, like we talked about. Bowel function can change. So we do talk, obviously, like I said, about bowel health. Constipation, is quite common post-menopause, as well as IBS symptoms. So food sensitivities that you never had before now become more sensitive to you, okay? Again, that vulvovaginal pH changes. So if we're talking about acidity versus base, we'll find that through with this decreasing estrogen, that there is an increase in the pH. So it's becoming more base or alkaline, where we want it to be more acidic. I know that sounds quite counter sometimes, but that acidity really helps the bacterial flora. And that's why we start to see some increase in yeast infections, UTIs into postmenopause, okay? So with that, they've then created a term that sort of all encompasses some of these changes that do happen to the vulvovaginal area and the lower urinary tract. It used to be called vaginal atrophy, which just sounds terrible. Just sounds like it's shriveling away. But they now, they now call it the genital urinary syndrome of menopause, GSM, okay? Yeah. Probably a male-driven title that we have decided to change, okay? So the onset of GSM, some of these changes tends to happen 1 in 7 years after menopause, and by 10 to 7 years, let me say that again. Between 1 and 7 years after the final menopause, a lot of these GSM symptoms, signs and symptoms will present. And so this is where you might not see this early on in perimenopause. You might be noticing, with intercourse, I need to start using lubricant a little bit more through certain phases of my cycle, or it just gets a little bit harder to hold my pee as long as I used to. So there might be really subtle signs early on in perimenopause. And again, a lot of these become a lot more prevalent kind of that 7 years after your final menstrual period. And I would say that I see that quite clinically as well. So on your handout, you'll see them there, some of the symptoms. So symptoms being like, what am I physically going to feel in my body? Okay. What am I sensing? So you might find that there's vaginal dryness. There's a decreased lubrication with sexual activity. There's discomfort or pain with sexual activity, potentially bleeding, again, just depending on that tissue quality, decrease of arousal, orgasm, or desire. So it's not necessarily your decreased libido, but it can be the fact that some of the nerves around the clitoris, or because there is pain, that there is this general decreased arousal with it, okay? So that's more what they're alluding to here. You can have irritation or burning, itching of the vulva and vagina. Dysuria is pain with urination. And again, that's often because of the tissue quality is kind of raw and irritated, and urinary frequency and urgency. So these can be symptoms related to the actual tissue quality, but they obviously also, some of these urinary symptoms sound a lot like a UTI. So we do need to rule that out, especially any of my women that come in that are in postmenopause, even perimenopause, that have this new onset of urinary issues. I often suggest that you just go get a urine sample just to rule out that it's not a UTI. If it's something that's been going on for years and years and progressively worsening, okay, we can probably say it's related to some of these other issues, but anything new, I usually suggest a urine sample. So some of the signs, so these would be things that we objectively could look at and measure that would be a sign of this GSM. So there's, again, we would see this decreased moisture and elasticity. And the best way that I can describe it when we look at the vulva, it just looks tight, like not in a good way. Like the tissue looks tight, okay? It's a hard way to describe it, but that decreased moisture and elasticity. The labia minora, so we have our labia majora, which are the large lips. The labia minora are on the inside. They actually become smaller and they kind of reabsorb, okay? We might see that there's tissue fragility or the fissures. So the fissures are just like little cuts, essentially, or tissue breakdown. That can be quite painful. Urethral eversion or prolapse. So the urethra where the urine comes out actually becomes larger. The opening, the meatus, actually enlarges as well. And that's one reason why UTIs also become more common in postmenopause, because that opening of the urethra, it's easier to trap bacteria, plus that change of the pH, okay? The prominence, we talked about the urethra, the introital retraction. So the introitus, the opening of the vagina, becomes smaller. And so again, that can lead to a lot of issues with pain with intercourse because it's actually getting smaller. And again, those urinary tract infections. We will also see that there is a shortening that's not on this list, excuse me, it's not directly related to the GSM, but again, something that does happen. The vagina itself becomes shorter and more narrow. So again, if we think in the context of penetrative intercourse, then that could be problematic and lead to some issues. So with all that said, there's help, there's things that we can do to help this, okay? So based off of we just kind of touched, sounds terrible. We should all just be peeing our pants off of that. So from there, the four main issues that we kind of want to talk about related to perimenopause, menopause is incontinence, and I'm going to keep it pretty specific to urinary, okay? Prolapse, dyspareunia or vaginismus. Dyspareunia is basically just pain with intercourse specifically. Vaginismus would be more saying that there's pain of the vagina that could be relating to different things other than intercourse, okay? And then the general tissue quality changes that we kind of just went over, so I'm going to be pretty quick with that, but give you some good treatment options. Okay, so again, incontinence, there is different types of incontinence. Stress incontinence, where there's this involuntary loss or uncontrolled loss of urine, typically in response to a pressure or force that we can't maintain that closure pressure of the urethra, okay? That's the most common that we see in postmenopause, and generally I would say is the most common. But there's also urge incontinence. So, oh my gosh, I have to go to the bathroom right now or I'm not gonna make it and I'm leaking, right? Yeah. So, you know, going into the house, change of temperature, someone just suggests, I have to go pee. Oh, I have to go pee. Yes, I have to go pee right now and I'm leaking, okay? Or walking to the washroom, maybe it's not quite so passive where I'm just like starting to pee my pants, but I'm walking to the washroom and I can feel that I'm leaking, okay? There's mixed incontinence, so you can have both. You can have a little bit of stress incontinence and a little bit of urge incontinence. One's usually worse than the other. And then there is overflow incontinence, where essentially the bladder is so full that it just kind of is dripping out. So when someone comes in and tells me I'm just passively leaking, I'm like, we need to explore this a little bit more. It's a bit different of a condition, okay? So again, we're gonna talk mostly about the stress and urge incontinence. So why does this happen? Again, this is what we're trying to figure out from the physical assessment. There's so many reasons as to why we might be leaking. And I'm gonna try and keep this also in the context of exercise a little bit too, knowing that this was part of sort of the Lift Heavy Shift program, that potentially leaking is an issue in some of these workouts. So it could be just basic pelvic floor strength. If pelvic floor isn't super strong, we need to improve that strength of the pelvic floor. But I also say that it needs to be like, we need to assess the dynamics of the pelvic floor. So do you have the ability, maybe you can come up, but you can't relax that pelvic floor. You're just kind of holding it up there. So we don't have this nice dynamic pelvic floor that can contract and lengthen. And I've assessed many women where they come in, they're telling me that they have leaking with their exercise, and I assess them, I'm like, your pelvic floor is pretty strong. I just don't feel like you're actually relaxing it. You're just kind of like holding it. And so it can absorb and respond to those forces that are being thrown at it, okay? Poor pressure management. So if we're thinking about this extra stress to the system, what's happening in our container from our throat to our pelvic floor? What's happening in this pressure system? So every time we breathe, inhale, exhale, engage, we're changing that pressure in our system. And if we're not matching that or overstressing our pelvic floor, then maybe we're going to get leaking. Poor coordination of the pelvic floor, it's just not responding when we need it to in response to an impact or a cough, etc. Again, we talked a little bit about that loss of sphincter tone, the tissue quality that influences that ability to create a good closure around the urethra. We talked a little bit about the fluid. So there are bladder irritants that might be increasing that urinary urgency and then setting off this spiral effect of our whole nervous system that's contributing to leaking. So very often with urge incontinence, pelvic floor is actually not too bad. Like it actually feels pretty strong, it contracts and relaxes. And that's where we're looking at these other factors that are maybe contributing to the leaking piece. So the other parts that can be, in, again, why you might be having leaking is the urinary tract infections, certain medications. Constipation does actually irritate the bladder, might not cause the full leaking, but definitely irritate the bladder. And we can't, again, rule out that there's a potential of bladder cancer. So again, if you're not responding to treatment or other warning signs, then I send back to your family doctor, okay? Not very often has that come up, but we need to keep it on the radar. So again, with assessment, we're looking at the whole person. We're taking this biopsychosocial approach. We're considering all these factors of what you're putting in, what's your stress, how's your sleep, what exercise are you doing, when does the leaking happen? We're really figuring out for the individual what's maybe contributing to this. The physical assessment, we're looking both externally and internally for that pelvic floor. And really important, especially with stress incontinence, we have to look at the functional movement. So, you know, it only happens when I run. Well, okay, let's get a video of you running. Let's work with somebody to do some gait retraining, right? We have to look at what's happening when we're doing that action potentially, okay? So treatment, again, there's so many options that we can do for this. And I'm kind of throwing this stuff out to you more as to pique your interest, to know that these are some things that we might involve. Sometimes I only do one thing, sometimes I do all of these things for individuals, okay? So obviously pelvic floor retraining, so teaching you how to do appropriate Kegels. We're training the system just like Jess described in her talk about, you know, strength training, endurance training. We're targeting fast twitch muscles, slow twitch muscles. So we'll teach people to do very quick contractions. We do slow sustained contractions. We have to train that pelvic floor to respond to the task. Core hip strengthening. So Sarah and I, before the whole start of this program, talked about the importance of hip strengthening, and just we talked about how she was going to emphasize building that into the program to build up the strength to help support the pelvic floor. We know the piriformis and the obturator internus muscles, deep hip rotators, do work to support the pelvic floor, likewise with glutes. So we can't ignore those pieces. And a research study I just saw, don't ask me specific details, but it was looking at women that did specific pelvic floor training and women that did pelvic floor training and hip strengthening, and they had faster gains in that group than those that only did the pelvic floor training. Okay, so again, just, oh, they told me I should be doing Kegels, but my symptoms aren't getting better. Sometimes there's more to it, okay? Again, we do education and exercises about pressure management, functional retraining, talking about your fluid and diet intake. Sometimes we need to do some medications. There are medications that really do help the urge piece of it, okay? I just lost that slide, sorry guys. There is also a really interesting product out called Uresta. It's a product that you can buy over the counter. So this is more of a support that you put into the vagina. Sorry, I'm off of the medications. I'm onto this insert into the vagina that you can buy. It's over the counter. It really does help with more of that stress incontinence, specifically with exercise. They have a money back guarantee. So if it's not working for you, send it back. And it's a Canadian product as well. So it's basically like a little silicone hard plastic that goes up into the vagina. The way it's designed is it creates a kink in the system around the urethra, and it's kind of a quick fix if you're having concerns with leaking. I would obviously advocate that if you are leaking, you should still get a physical assessment and get the appropriate exercises. But if you're like, you know, I just need to work out and I need to not leak, I'll do my exercises and reassess as I go, great. This can be a really good option. It has about a 60%-ish success rate. So yeah.
Dive on the whole incontinence in our location on Tuesday morning, and one of the girls she's
Yep.
And it's a huge difference. So we say
similar, yeah. So Sarah was just saying that they had some discussion around in one of the workouts around incontinence, and one of the participants uses her Diva cup. So it's similar. I definitely have heard some patients have some good success with just using their Diva cup, because as Sarah was saying, it creates like a bit of a pressure against the urethra. I've found sometimes, again, just with the size potentially or the woman's vagina, it's hard to keep that in. So both kind of, they don't always work, okay? We'll talk a bit about a pessary more in the context of prolapse. It's a similar device, that structure that goes into the vagina that can help with incontinence. Other treatment options is, again, addressing the tissue quality, and there is external and internal stimulation for the pelvic floor muscles specifically, that can be really helpful as well. And some of those you can just buy on the internet that work really well, okay? So that was a really quick overview of incontinence, okay? Next, we're gonna go on to prolapse. And this is one that I find I get a lot of mixed messages, whether people have a good understanding of what prolapse is or not, okay? A lot of times it's not. Either they've never heard of it, they think they have a tumor a lot of the times when they first think or are aware of this prolapse, essentially what it is a loss of fibromuscular support of the pelvic viscera. And wherever that area of weakness is, that organ is going to descend or fall onto the vaginal wall. That's the key there. Your bladder is not going to fall out of you, okay? It's going to fall onto the vaginal wall. Many women come in and be like, I'm just so afraid my bladder is going to end up on the floor. Like legitimately, they think the organ is going to fall out of them. It's not, it's still intact and it's pressing on the vaginal wall, okay? So if we go back to the model, actually, I think I'll just use this. So the bladder is sitting on the top of the vaginal wall, right? And the rectum is on the back of the vaginal wall. So they kind of sit like this. What we don't see in that pelvic model is that there are also ligaments that anchor the organs to the bones, okay? And there's also connective tissue or viscera that sort of like a spider web connects everything inside. So if, again, we know that estrogen is decreasing our whole elasticity of our body, hence why we get wrinkles and why we might have more joint issues, why we get tendon issues with exercises in postmenopause, it can affect those ligaments that anchor the organs. So they become less elastic, okay? Then we also picture that those organs are sitting on the pelvic floor, and if pelvic floor is weak, it's going to create more drag onto those already less elastic ligaments that would anchor those organs. So there's going to be more drag that happens, and potentially then we start losing some of that support. So you can get prolapse of bladder, uterus, and or rectum, any combination, okay? You can have a little bit of bladder and mostly uterus or vice versa, okay? Bladder, excuse me, is probably the most most common, then uterus, and you can also get prolapse rectum, okay? So, sorry, not the most popular. So we grade that in the physical assessment. It's really important if you are getting this assessed that you get assessed in standing. Gravity makes a huge difference to how things I've definitely assessed women and be like, I don't really feel a whole lot laying down, but they have symptoms of prolapse. So I get them to stand up and I'm like, oh, there it is. Okay. So it can really drastically change. It can also vary in severity or grade of the prolapse. So we measure that on a scale. 4 is the worst, the max. It is sitting outside of the vagina most of the time. 0 is there nothing. Okay. The most interesting thing about prolapse is that related with the degree of prolapse that you have. So I've definitely had women where it's a lemon-sized bulge. I can see it lying down in their vagina. They're like, oh, my prolapse today is pretty good. I'm like, okay, yeah. And other women where it's still inside the pelvis and they'll have symptoms of pressure, heaviness, fullness, this sensation of a tampon stuck in the vagina. If you've ever had it start slipping out a little bit, that's sometimes what prolapse can feel like. You can have associated low back or lower abdomen discomfort. Again, just everything is connected. So fascially, it's sort of pulling. And so that might be some side symptoms associated, but typically it's not painful. You shouldn't pain because of your prolapse. If it is, I'm definitely looking at your tissue quality because maybe it's this friction issue of your prolapse in a dry vagina, and that can make symptoms worse, okay? So we talked about some symptoms. There's pressure, heaviness. It can, particularly when there's bladder prolapse, which is called a cystocele, you can have urinary issues associated with that. So you might have urgency, frequency, leaking. Again, just because of that loss of support, you stand, change position, and things kind of move around and you might get some leaking or that sense of needing to void, okay? It typically might come on later in the day or after exercise. And so again, during exercise, that doesn't have to be a sign that you need to stop. If anything, we need you to keep strengthening, but in an appropriate manner that doesn't overstress your symptoms. We need to, again, meet where you're at, but we need to support all those muscles. I've seen so many women through COVID where all of these symptoms got worse because they stopped going to the gym or they were working from home and they weren't getting up and moving around as much. And then basically, again, they've lost some of the strength. They've lost that dynamic pelvic floor that they maybe had. So I definitely feel, I don't know if it's coincidental because they're 3 years older or if it's because of COVID, but I just feel like there's a lot of this change of routine for exercise that really does influence that pelvic floor. And there was an interesting study that came out from 2020 that actually found that women that lifted heavy, and I will be honest, I know it's for postmenopausal women, but I don't know age groups or real specifics on it. Women that lifted heavy actually had less symptoms associated with their prolapse. So just because you have prolapse doesn't necessarily mean you have to stop lifting or stop exercising. I hear that a lot. We just need to help tailor it a little bit better for you, okay? Treatment, again, we can do very conservative treatment, focusing on pelvic floor, pressure management, core, hip strengthening, all those same things similar to incontinence. But we might need to go a little bit further with that. Again, addressing the tissue quality, addressing your bowel health. So a lot of women that have prolapse also have chronic constipation. So you have to get your bowels in check, soft formed, easy to pass. Doesn't matter how frequently you go necessarily, but as long as you don't have to strain from a pelvic health point of view, okay? Yeah. We talked a little bit about a pessary. The best way I can describe a pessary is like an old school diaphragm. So it's usually roundish. There can be cubes. There's different styles. There's some that are quite flexible, and there's some that are very rigid and formed. They can stay inside of you for up to 3-4 months before you get them cleaned. And for younger population, there's definitely ones that you can just use for exercise. So, you know, if long runs or heavy lifting, you can get some that you like, gonna put on my knee brace, I'm gonna put in my pessary. That just provides a structural support to the vaginal walls, so you're not feeling symptoms. Again, if you have a pessary or think you want a pessary, I always advocate that you still do some of this work. I have definitely seen older women, mind you, where the pessaries stop working for them because their prolapse worsens. They probably haven't addressed their pelvic floor, their bowel habits, their breath, their core, etc. So you still need to do this work, but it can be really helpful for supporting, okay? That is something that needs to either be fit by a gynecologist. There are some specially trained physiotherapists that do it, but the only woman that I know, she's in Barrie. She has like a huge wait list. So you typically have to go through your gynecologist to get fit for a pessary, okay? From after doing sort of this conservative work of some of the physiotherapy, the exercising and strengthening, maybe trying a pessary, if things are still not improving, then the next step is often surgery, okay? At any point, you can still advocate and the surgeon will probably give it to you. It might take you a really long time at this point, post-COVID, but you can always get a surgery that helps suspend and repair. I'm not gonna go into great detail and it's a bit out of my scope, but that's usually the next level. Most surgeons wanna know, have you done the work? Have you tried this before we do surgery? Because we want that repair to last you like the rest of your life, ideally. And I do say to women, sometimes they come in, they're rarely, I find in our population, or at least my practice, I don't get many women saying like, I want my surgery. They're usually wanting to avoid it, but you have a good 6 to 8 weeks of not doing anything except gentle walking. There is a 30% failure rate of it. And usually there's lifting restrictions thereafter. So you need to take all that consideration to this quick fix, okay? Okay. Very quickly about Kegels, because again, just in terms of incontinence and prolapse, those are kind of some pretty big important pieces, is addressing the pelvic floor strength and dynamics like we talked about. Some of the big points around Kegels is that we need to really only use that if pelvic floor muscles are weak, okay? If we're looking to build that strength and muscle bulk and tone of the pelvic floor, then yes, Kegels are great for you, okay? If it is a very really tight in the sense of holding a lot of tension, we're going to talk about maybe more the tissue quality type, but if it's tight in the sense of holding tension, then Kegels aren't necessarily great for you. You're not going to be relaxing that pelvic floor. You're not going to be getting this nice up and down that we're looking for. It needs to be still quite dynamic and fit with that specific tension that we're looking for, okay? And I would say in my practice, probably at least 50% of the time when women come in leaking, I'm getting them to relax their pelvic floor more than anything and looking for more of that dynamic, that like mobility of the pelvic floor, okay? Again, what we see in research, some of the best way to determine that state of the pelvic floor is through palpation. So a lot of women come in like, do I really need the internal? I'm like, you don't. We can go through it, but it's going to give you the best indication of what your pelvic floor is doing. Okay. And how you contract is also really important. So like that little visual that we started with, we want to feel a tightening and then a lift. Again, so what we can assess with internal palpation is sometimes I feel people like lift and then tighten. And that's something that we learn and try and educate patients on, of how to be doing those Kegels appropriately. Okay, so how we contract that pelvic floor. I work in the gynecology office here in Collingwood, the Collingwood Obstetrics and Gynecology, and sometimes Dr. Yates will send me a referral and just say like, doing Kegels wrong. So I just need to retrain how they're doing as well. Okay. The other interesting thing, if anybody has a vibrator, like I said, we talk really openly here. If anybody has a vibrator, it can be really helpful for stimulating some extra pelvic floor contraction. So if you're looking for a little extra stimulus to get your pelvic floor going, they actually found that once a week for 20-minute sessions, 6 weeks of it, they had better outcomes than doing like an electrical stimulation inside the vagina. So there's devices that we can put into the vagina that elicits a contraction. If you've ever had physio where they put the pads and your muscle starts twitching, we can do that in the vagina as well. But we found like quick and easy is just using a vibrator. You can put that in. Great, good. You know, do it yourself, little pelvic training. Again, if you need to be doing Kegels, okay? If you need to be doing Kegels. Okay. Once a week for 20 minutes, which I thought was a pretty good value, pretty good bang for your buck. Okay, so this might be a little more relevant for those that really are involved with fitness. Hopefully some good points for some coaches. I figured there was going to be some in the crowd. Again, leaking in that prolapse symptoms isn't necessarily just because of a weak pelvic floor. I hate when I get, people coming in saying, oh, I was just told to do my Kegels. And I'm like, there's so much more than that. Again, their assessment can be really helpful to identify. And as coaches, there's so much that we can do to help modify for our patients to keep them physically active. So we need to consider all of those variables that might be causing extra stress to that pelvic floor and creating this in a progressive manner so that the body can adapt. Okay, again, much like Jess talked about in her talk, we have to progressively load so that the body then adapts, okay? If we just stop exercising completely, that's gonna be very challenging to adapt to and get stronger with. So we can adjust the load that our clients are using, how much weight are we asking them to lift, the depth of their squat. So if anybody needs to get up and move, if we just do some squatting here, we're not gonna create as much demand on the pelvic floor as if we go way down and create more pressure and more opening to that pelvic floor. So again, if someone has prolapse symptoms, then maybe we just get them doing 3/4 squats for now, okay? Keeping them active, keeping them moving, or looking to other variations that don't create such a deep squat for now, okay? The speed at which they're going. So again, if it's a coordination issue, and again, we're talking a bit about leaking, if it's a coordination issue, then maybe if we just get them to slow it down, can they absorb better? Can they breathe better? Can they coordinate that contraction a bit? The amount of impact. So for example, jumping jacks, most women don't love jumping jacks, but if we start with low intensity and slowly build that speed of the impact, maybe the body will adapt a little bit better to that, and we can find a way to keep them getting a cardiovascular fitness. And again, the form. So I would say I see that a lot in running specifically, as well as skipping. So I get some CrossFitters that come in doing double unders, and more times than not, it's the tension and the form that they're doing that's going to be creating that extra stress. And if we just change it, it can often make a big difference. So for example, an easy little takeaway, if you are a runner, and I'm going to do this, but you see the people that run like this, right? Down the road, okay? They're very upright. They're very upright and kind of really stiff and erect. There's not a whole lot happening. Well, you want to have a sensation that you're kind of leaning forward into that run. So really simple tasks that I give clients is just start leaning forward from the toes and ankles, and you should take a step. And that's sort of the angle of propulsion that you want to have that will create some good bony support for the organs, specifically the bladder, as well as help that pelvic floor to absorb that force a little bit better. Okay, really, really simple, quick and dirty. But just as an example, how form can play a role. Same thing with skipping. People that are like up here when they skip, right? What if we just soften a little bit? Or what if we relax the shoulders a little bit? Can really change, again, that pressure management and how the pelvic floor can react, okay? So again, we shouldn't have clients stopping exercises because of leaking or prolapse. We can keep them going if we just consider all of those principles of training that we can modify and vary, okay? So points to consider, and some of these are, again, like my quick and dirties and really big global principles that I apply for a lot of my clients. So pelvic floor strength and that dynamic. So I really use this example of a trampoline. So maybe some in the class, in the group here, or we've seen some clients where they skip and they're like holding like everything as tight as possible. That can actually be of a detriment. Eventually, it's like this trampoline that's pulled really, really tight. The springs are tight, the like fabric is tight. You're gonna blow through that eventually, okay? That pressure is too much, the tension is too much, okay? Likewise, if you have this loose, saggy trampoline, springs are slack, fabric is slack, well, you're gonna blow through it and you strengthen. We want that nice trampoline that absorbs the force, that comes up and down and can respond to that pressure and force. And that's actually what we see in the pelvic floor. They've measured, they've put electrodes on and had people jump, and the pelvic floor lengthens and comes back up in response to that force. It's not just up, 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 up. So we need it to be nice and dynamic. That overall tension, so a concept of which I've stolen from another physio, tension to task. So how much tension do you actually need? If I'm gonna pick up, a 25-pound weight, do I need to be like bracing super hard versus like 150 pounds where, yeah, maybe I need to generate a little more tension in my body, okay? So looking at how much tension is our client generating, or you and yourself, am I bracing really hard? In terms of the core activation, so yes, generally building up that strength, endurance, coordination of our core, but just again, more globally, how are they engaging? So the example I like to give is I tried to find a balloon, but I threw them all out because my kids were blowing them up and popping them. So I didn't have a balloon at home, but if we pictured a nice balloon and we squeeze that balloon, like our core, bracing like specifically with the obliques, right? So if we're really kind of clenching in and squeezing around our core, what's gonna happen to that balloon if we squeeze it around the center? It's gonna blow, bottom out, is gonna come down, right? Bulge, and then that pressure. So it's kind of, again, if we're over bracing with our core, can create excessive pressure and force down to the pelvic floor, okay? Again, that intra-abdominal pressure, so we've kind of just gone through this sequence here, this general overall tension, this core activation, and then this intra-abdominal pressure. Really simple strategy, just blow before you go. So if you're gonna squat, exhale as you come up. Some people actually do better if you exhale all the way through the motion. We do know that breath hold or that inhale can give you a little extra strength. So this might not be for like maximal lift, but looking again at your clients and at yourself, am I breathing? Most of the times I ask clients like, how do you breathe when you work out? Like, I don't know, I just hold my breath. Well, let's just get some of that pressure off the system and focus on blow before you go, okay? So really quickly, I knew I was gonna have a hard time keeping this to an hour. Sorry guys, we okay? Okay, dyspareunia, vaginismus. Again, a lot of these last two, the dyspareunia and the vaginal tissue qualities, comes down to those hormonal changes a lot of the times in this population. With dyspareunia, that is pain with intercourse, like I said. So we can hone in on the tissue quality if you have no prior history of pain with intercourse. If you are someone that has a long, deep-seated history through trauma, abuse, all those sad stories, then that's a different demon we're dealing with. We have to dig a little bit deeper. If this is a newly onset progressing through menopause, then yes, we're gonna probably address that tissue quality. But specifically with the pain with intercourse, the tissue quality is a piece of it. Because if this is something that's been progressively building through the years, you're gonna build up this pain cycle, okay? Where, okay, it hurts, I'm a bit apprehensive, is it gonna hurt this time? What do we do when we feel pain? We tighten up to it. So now we're gonna create this tighter vagina that has poor tissue quality and make more friction, okay? So yes, we have to address the tissue quality, but then we still have to look at what's your pelvic floor doing? Can you relax the pelvic floor well? What's some of the emotional pieces that are connected? Do you trust your partner to kind of go slow, etc.? there's a lot more than just the tissue quality with this. And so we need to break that pain cycle and make you feel really confident that you can either, the tissue quality will kind of withstand that force and friction, but also that you can accommodate the vagina, like we talked about, narrows and shortens, that you can accommodate penetration. Okay, and those are some strategies that we go through in the clinic. So again, addressing the tissue quality, looking at the pelvic floor of how well it relaxes and contracts. We do use dilators, which basically look like your basic vibrator, kind of straight vibrator that progressively gets bigger in size. So it dilates or opens the vagina, progressively stretching it. So again, this is probably like older, kind of long-term potential, not having intercourse, more advanced sort of tissue quality, that we might need to bring in something with that. Okay. Again, I would say dilators need to be specifically prescribed. There is a product, I think I just added this one, so you might not have it on your notes. It's called an O-nut. So if anybody has pain with deeper penetration, it's basically like a cock ring that you put on the penis, so it stops them from penetrating deeper. And a lot of women really like it. Probably free. Okay. I do talk about for some of my clients sex therapy. There is a sex therapist in town. She's amazing. But again, thanks to COVID, our virtual world, you can hire pretty much anybody, anywhere for that. And we do need to calm that whole nervous system. Again, thinking about this pain cycle that tends to happen if we are guarding and holding tension in the pelvic floor. We need to look at strategies that really, really calm that whole nervous system so the pelvic floor can feel really safe and relaxed. And always, always, always use lubricant. So I've given you a sample of water-based lubricant can be super helpful. If you start normalizing it, it's just part of your sex life. It becomes commonplace, and it should make things better. This one's water-based. There's oil and silicone and good old coconut oil you can use as well. My disclaimer, obviously you need to do some testing and check for yourself, and not everybody is great with all products. So just do a little sample, spot, and make sure there's no allergy. You also need to be careful with different lubricants. You can't use oil with condoms, excuse me, if you're still using condoms. And you can't use silicone lubricant on toys. It can degrade the plastic or silicone. This is the podcast that I listen to educate on, is different types of lubricants. All right. So like I said, that's pretty quick. It can be a big topic. That's sometimes what women just specifically come in to see me. Last couple minutes here, guys. Sorry for running over. Just vaginal, the vulvovaginal tissue. I think we talked quite a bit at the very beginning about some of those tissue changes that do occur because of the decreasing in estrogen and progesterone. So number one thing, we talk about hygiene, a great word, but it's something that we use, some more vulvar care. Don't use soap in your vagina. I know we think it's kind of dirty, or we've been exercising, we really want to clean it, but it is more drying. Okay, it's going to change that bacterial makeup, and it's going to dry the tissue out more. So if you've done a good workout, just like go to the growing area, but don't go up into the vagina. Even if it's a pH balance, Vagisil, whatever cleaning stuff that they have for vaginas, just water is great. Okay. Consider your underwear. Cotton is best. Thongs aren't great. The toilet paper, if you have real sensitivity to the vulva area. Bidet is really great, again, for more severe tissue quality, and no underwear at night to let that tissue to breathe in air. Okay. Some treatment options. Again, I can't prescribe local estrogen, and that's probably, again, a whole conversation in and of itself, but lots of really positive research coming out about local estrogen that does not have any risk factors for cancers, dementia, or cardiovascular disease like you will read on the box. They are basing that off of postmenopausal women who are taking oral hormone therapy, okay? So if that is something that is of interest, you would definitely speak to your family doctor, your nurse practitioner, your naturopathic doctor, and or gynae, okay? Also, I've seen some really positive research coming out about non-hormonal vaginal moisturizers have some really positive effects on that tissue quality. You want to look for something that has hyaluronic acid. Sounds really scary, but can be really nourishing and healing for your tissue, okay? And we're seeing in the research some positive outcomes similar to using local estrogen. So really great for any women that do have any cancers that are estrogen driven, okay? Vitamin E also came out in a study, seeing really positive results similar to the hyaluronic acid. So if you want something even a little more natural, that would be great. And another training program, pelvic floor training program, they actually saw this as a side outcome, that women who did this 12-week pelvic floor muscle training program, we actually saw an improvement in their tissue quality. And they're thinking that that's because of just contracting, relaxing, getting blood flow, getting muscles contracting. We actually saw an improvement in their tissue quality. So again, another reason that Kegels can be good. And that's where I was kind of alluding to tight in the sense of muscle tension versus tight tissue because of tissue changes, okay? I've put some resources down, some stuff, again, pretty specific to perimenopause, menopause. I'm currently reading the Menopause Manifesto, which is really great, by Dr. Jen Gunter. She's lovely. Come as you are in terms of any sexual health stuff. I think it's just something really important for all ages, no matter where you are in kind of your sexual experience. Is a really great book that really, I've learned so much from it. I think every woman and partner should read it and read it together, maybe. Give it to your husband for Father's Day, if you have one. My website, I have some good blogs on there. Menopause and You is another great website. Menopause.org, again, another great resource for any menopausal sort of related questions. Okay. I also think, I don't know if I put on that. Dr. Rachel Rubin, she's another, if you have more questions or wanting to learn a little bit more about hormones, she's a huge advocate. She is an American doctor. But she has some really great resources, as well as the podcast that I think I put on that sheet there called the Pelvic Floor Pelvic Floor Project. She's a Canadian physio and does interviews with lots of great healthcare providers. Okay, it's really just about educating yourself and advocating if there are things that you need. Okay, so if you do need pelvic floor physio, you may or may not need a referral to your family doctor. It's mostly just if you have private insurance, you might need one for that insurance plan. Definitely book an appointment then and commit to your treatment plan. That's the number one thing I find the biggest challenge for people is just doing the work, okay? I've given you my contact info at the very bottom if you do have questions, and I think I'll put a little blurb out for people to send me some questions so that I can answer privately. But if everybody's okay, I'll share it with the group potentially, but obviously leave out any names or personal information. So if you do have some questions that you want to ask, I can put it out so everybody gets to learn from everyone else, because no dumb question. So that was, I'm sorry, I ran over. I knew that was going to be hard to do. Does anybody have any questions right now? Yeah.
So what's good prevention? Like I have the issues and I don't want them.
Yeah. Yeah.
So what do I need to do to avoid all of it?
Yeah. Yeah. So the question was, what can you do for some prevention if you aren't currently having any of these issues? So some of it, I think, is just being aware of this. I don't think, maybe you don't need to do anything at all. It's totally up to you. But I think just being aware of what are some of your options, what are some things that can present, so that if you are in the shower one day and you feel this bulge, you don't think it's a tumor, because literally I have many women come in and tell me that, oh, maybe it's a prolapse and I need to get this looked at. Okay. So maybe it's as simple as that. Otherwise, get an assessment, like whether it be through your family doctor, looking at your vaginal tissue, doing a PAP and assessing your pelvic floor, seeing a pelvic floor physiotherapist to get a baseline assessment, looking at your posture, your alignment, hip strength, all that stuff, pelvic floor would give you a baseline, so that in 5 years, you can be like, oh, I feel like things have changed, potentially. Okay. Yeah. Does that help? Yeah. I feel like there might be a question on the Zoom. Oh, great. Okay. Any other questions? That was a great one. Yeah, because not everybody's going to have this. Again, it sounds so doom and gloom that, we're all just going to end up peeing or having our uterus fall out, but it doesn't have to be the case. Okay. Yeah. I do find that really helpful. I advocate for that a lot because it really does work on your hip. Oh, sorry. The question was, is Pilates a good option for this? Prevention as well. Yes, I do support it a lot. I refer quite often. I know Active Life has amazing Pilates instructors here. I love Lisa. So yes, I love it because it works on all your stabilizers. It works on your hip mobility, core mobility, spinal mobility, all of those pieces that are super important, as well as the core. What I do find, having a couple of sessions one-on-one, either with a pelvic floor physio to talk about like, how should you be engaging? How does it connect? What does it feel like to engage your pelvic floor with your core? You know, looking for some of those changes, because maybe in a group class, they can't see, you know, you're overusing your obliques, or you're bracing too hard, or, you know, when you're engaging, you're actually bulging more, right? So a couple of individual appointments can be really helpful. And then I set you free, basically, like go see a good Pilates instructor that can give you a huge range, but let's make sure have a good knowledge of what that should feel like in your body. Great question. Do you have any more questions? Great. Anything else? Something pops up in the middle of the night, send a message. Yeah. Okay. Awesome, guys. Thank you so much. Thanks, Sarah. Thanks, guys.
Thank you. That was great.
Thank you as well.